testing. Hep A should definitely be done with someone who uses injection drugs. Or we had a patient who came in a couple of months ago who spent about 20 minutes talking to me about. So we certainly also got him a hepatitis A test. And we get one every time he comes in. So great. Now you're going to do your counseling and education. So PrEP, again, the efficacy is highly dependable on adherence. The time to protection is about 1 week for receptive rectal exposures and about 3 weeks for other exposures. We actually don't have data on how long it takes to reach like the penile tissues, but we kind of lump that in with the 3 weeks for the other exposures. PrEP does not protect against other STIs, and so of course you want to incorporate other prevention strategies as well. Side effects are uncommon. They usually resolve in the first month or so and can be treated with over-the-counter medications. Most common ones are headache and GI symptoms. If somebody is Hep B positive, again, they may have a flare if their PrEP is discontinued, so you want to make sure that someone who's Hep B positive is well aware of that. You want to discuss U equals U, especially if that person is in a discordant couple with someone who is HIV positive. And you really want to hammer home the importance of routine testing and follow-up. And then also how to navigate the pharmacy. A lot of our patients on PrEP do not have interactions with the healthcare system in other senses. Again, we really have been targeting it towards MSM for a long time. They don't go to like GYNs every year. Like this younger population isn't necessarily used to doing routine medical visits. So you want to make sure that they know that's important. And then you also want to review your discontinuation procedures. We usually tell people, hey, if you want to stop, let us know. We'll stop your refills. If you ever want to start again, please give us a call so we can get that HIV testing before you restart. Again, side effects. The emergent side effects, which are very rare, include lactic acidosis and hepatotoxicity. I think since I've started working with PrEP in 2013, I've had one person who's had to discontinue from lactic acidosis. So it is very rare, but you certainly want to counsel people on it. The only reason we knew this guy might have it is because we had gone over the symptoms with us and he called and said, I have those symptoms. And I was like, there's no way, but he did. And we got into the hospital and it all worked out well. Short-term side effects, again, are those headache and GI symptoms. And then long-term side effects, they're more common with TDF-FTC, are renal impairment and bone mineral density loss. So if you have someone who already has renal impairment or is already at high risk for osteoporosis, you may want to consider treating with TAF-FTC. The only caveat is that TAF-FTC has only been tested in people who were born with penises, so should not, per guidelines, be prescribed to people with vaginas. And then the weight gain with the TAF-FTC. All right, and then you're going to write the prescription. So you can either write for TDF-FTC or TAF-FTC. TDF, again, should not be used if the creatinine clearance is less than 60 mLs per minute. It's also available in generic form, so most insurance companies are covering that over the name brand form or TAF-FTC if that's not available in a generic yet. TAF-FTC is 1 tablet by mouth once daily, should not be prescribed to anyone whose HIV risk includes receptive vaginal sex. It has not been studied in that population, and it should not be used if the creatinine clearance is less than 30 mLs per minute. You can take them with or without food, it doesn't really matter. There is on-demand dosing, or also called 211 PrEP. We also do this in our clinic, and you can look up, the new guidelines actually have some great pictures of on-demand dosing and how to do the scheduling. But it's basically you take 2 tablets before sex, 1 tablet 24 hours after sex, and then another tablet 24 hours after sex. And it's not recommended for people whose risk factors include receptive vaginal sex or injection drug use. It's only been tested in men who have sex with men, so that's the population that CDC has kind of allowed for with it. And it's really great for people who can really plan their sex and are having on average less than 1 episode of sex per week. So if somebody's like, I only have sex when I meet up with people from Grindr and I know when that's going to occur, this might be the best option for them. You usually want to counsel them that they may have more symptoms because they're stopping and starting. So those GI symptoms might occur every time they start it. So that's the only thing. And then you want to make sure that nobody gets more than 90 days at a time. So that can either be 90 days or 30 days with 2 refills. And just a note about injectable PrEP, this is very new. It was only approved in December. And it has a different schedule for labs. It's going to be every 2 months instead of every 3 months. The initial dose is at a first visit and then a second dose a month later, and then you move to the every 2 month schedule. And you do need RNA testing prior to every dose. It has a very long tail end of about 12 months where there's enough drug in the system, but not enough for protection. And so if someone were to develop HIV during that tail end, they could have an integrase inhibitor resistant form of HIV. They would still have medications to treat their HIV. However, the only injectable form of HIV treatment right now includes CAB, so they would be limited in that respect. It's extremely new. We're not sure which insurances, if any, are covering it at the moment. And we're also not sure, some insurances might cover it as a medical benefit and some as a prescription benefit, so that will change how it gets delivered to the clinic and provided in a clinic. However, it has been found to be much more effective at preventing HIV, especially in people who were born with vaginas. So that's a wonderful thing. All right, and then this is the follow-up and ongoing monitoring schedule. So for someone who's on oral PrEP, they'll be coming in every 3 months. And you should every 3 months be getting an HIV test. And then we always do all of the STD testing, all of the STI testing, regardless of whether they're MSM transgender or female or non-binary. Like, we do it for everyone just because of the high rates of STIs in Baltimore City. And then every 6 months for someone who's under the age of 50 or their creatinine clearance is for over the age of 50 or their creatinine clearance is less than 90, you'd get that every 6 months. Or if they are over the age of 50 and their creatinine clearance is over 90, you could get the CMP annually. And then Hep C serology for men who have sex with men and people with injection drug use should be done annually. And then you also want to make sure that they're picking up their medications, assessing adherence, and then also assessing access to syringe services programs. PrEP during pregnancy. PrEP is indicated in pregnancy, and actually people who are pregnant might have a higher chance of getting HIV if they're exposed during their pregnancy. Also, TDF, FTC is one of the primary medications in HIV positive women that's used during pregnancy, so it is a preferred medication in that group. So all of the studies we have are from people who already have HIV, but it's been found to be effective, and there's not a lot of negative side effects from it during pregnancy. And then paying for PrEP. This is always the thing that scares the most people. Is how do I pay for it? Insurance companies, again, are required to cover it. At least one. It may require the CPT modifier for the labs and the visits. And you may have to go through different prior authorization processes, which can be really frustrating. There are copay programs to assist people that have high copays on medications. The Gilead Advancing Access Services program is one of these programs, really the only one. It can provide copay assistance for people. And then it also has a patient assistance program for uninsured individuals. And then the CDC Ready Set PrEP program also can help patients who do not have medical benefits get PrEP for free. And that's just the pictures from the Gilead program. And this is from the Ready Set PrEP CDC program. All right, so we do a RN-led model of PrEP delivery in our clinics. Our nurses manage the PrEP panels using standing orders. They initiate and provide routine follow-up care for patients. And our care is provided in person and through telemedicine. The patients do see a provider, and the providers are notified when we have a new patient. They'll usually review at least the first set of labs with the RN. And then they see the provider annually, and if anything comes up that's off protocol. So if they're having symptoms of an STI, they'll see one of our providers instead of one of our nurses. And then the RNs are really ensuring that the patients are walking through this whole process and getting their medications. So this is kind of a flow of actually our rapid starts. And I guess you can't see up there, I'm sorry, but it basically starts with a patient comes into clinic and is diagnosed with an STI. We actually have our STI providers doing rapid starts now. We just started that about a month ago, and our PrEP initiation has doubled in the last month since implementing this. So the provider will get the rapid HIV test. If that test is negative, they will do basic counseling, obtain all the baseline labs, and then provide if we have starter packs available, provide the patient with a starter pack, and then hand them off to the peer navigator in clinic to work out the details of the insurance and what is needed. And then they'll notify the PrEP nurse, and the PrEP nurse will call after a day or two after to go over everything, make sure the patient picked up their medications, etc. This is if a patient calls and requesting PrEP, they would be scheduled on the PrEP RN schedule. The PrEP RN would do a rapid test if available. If not, we would do a conventional PrEP initiation, so they'd order the labs. And then the PrEP RN would do the education and counseling, the labs, which require a standing order, the insurance considerations, write the prescription, which does require a standing order, and then do documentation. They would then schedule that patient for a provider visit for the next 3-month appointment, and then they would see RNs for most of the visits following that. What's the future of PrEP delivery? Well, we already have our injectable. We're working on that. There are some other long-acting PrEP medications that are under investigation. Some places are working on pharmacist-delivered PrEP models where it will allow. And then also just keeping in mind the telehealth options. There's actually an app that I heard of recently, I had not looked into it, called Mister, which will do telehealth PrEP. So if you don't have any place to refer your patients, or if you're just wanting to do the rapid start and then hand them off to another service, that might be an option. Again, I haven't looked into it, but it sounded pretty cool. And these are the guidelines that I mentioned, and just other resources. Here's my contact info. I also do work with the Prevention Training Center that's putting on this program, and I'm the protocol specialist. So we're always happy. I'm happy to share our protocols, both for PrEP and express STI testing, as well as we can help you develop protocols and fit them into what will work for your clinic. So you can always get in touch with us. Are there any questions? Yes.
Please repeat.
It's an IM injection.
Can you repeat the question? Because the people can't hear it.
Oh, sorry. The question was, how is injectable PrEP administered? It's an IM medication.
Okay, I've got 2 other questions.
Sure.
Would you give a pregnant woman Descovy? Could you please repeat?
Yep, the question was, would you give a pregnant woman Descovy? You would not give a pregnant woman Descovy, and that is because it has not been studied in people who have receptive vaginal sex as an indication for PrEP. And so anyone essentially born with a vagina would not be eligible for Descovy in any situation, regardless of pregnancy.
And then the other question is there a role for injectable PrEP in the post-exposure patient?
Is there a role for injectable PrEP in the post-exposure patient? That would be very interesting. Right now, no, it definitely has not been studied. I think that it would be a good study to do if you want to do that.